So we just wanted to make sure that we acknowledge ev- everything that's going on. As Stephanie was saying, this is a very timely conversation. So in the wake of the state-sanctioned killings of George Floyd, Breonna Taylor, and countless other Black and Brown folks, we witnessed nationwide and worldwide civil unrest calling for racial equity. Although energized attention was recently brought to this issue, we know that, of course, this is not a new problem, especially in healthcare. Medical apartheid has been part of this country since its inception, with slaves being used for medical experimentation, hospitals using Black bodies for student training, and the continued segregation of care contributing to health disparities. The recent conviction of Derek Chauvin on all three charges for the murder of George Floyd is a step in the right direction. Police cannot always get away with state-sanctioned violence. Black lives do matter. Convicting Derek Chauvin is accountability, but it is not justice. We recognize that there is still a lot of work to be done towards achieving racial justice, both in healthcare and in our society as a whole. With that, we welcome our two amazing speakers who have been doing that work in the fight for racial justice. And I'll pass it to Stephanie to introduce our speakers.
Wonderful, thank you so much. That was well put and well said. So first, in no particular order, I'll introduce Jesus Gonzalez. So thank you for coming, first of all. So Jesus is a second-year medical student at Burrell College of Osteopathic Medicine in New Mexico. He founded a regional chapter for the Do No Harm Coalition, so a collective of healthcare workers and activists whose goals is to accompany communities in their struggles against state-sponsored violence, as well as eradicate systems of oppression to accessible healthcare. Jesus established a volunteer program at Oakland's Highland Hospital, caring for marginalized patient populations. Currently, Jesus is assisting with COVID relief efforts, working with border, rural, and indigenous communities in New Mexico. He also organizes community outreach events with Stand Up for Racial Justice, Black New Mexico Movement, as well as Direct Action Doña Ana. So thank you so much for coming. And then I'll just actually introduce Dr. Susan Rogers as well, and then we'll start with the questions. So we also have Dr. Rogers here, thanks again. So she is the president of Physicians for a National Health Program. Dr. Rogers received her medical degree from the University of Illinois College of Medicine and completed her residency in internal medicine at Cook County Hospital. She is a past co-president of healthcare for all Illinois. She previously was medical director of the Near North Health Service Corps and FQHC in Chicago and remained on their board for many years after. Dr. Rogers is a fellow of the American College of Physicians and a member of the National Medical Association. So with that, we welcome both of you and are excited to hear from you today. If everyone's ready to go, I'll read out a question, and of course, you don't feel like both of you need to answer, or if we go off a different route, that's perfectly okay, but we have a couple that we'll start with. So first question I have for you guys is, what perspectives and practices do you bring or wish to stimulate around healthcare that are missed or possibly overlooked by the traditional medical profession?
Well, I could start, from my position as with Physicians for a National Health Program, is that one of the biggest problems we have are inequities in access, in ability to receive care, financial barriers, and resources. And a lot of this is reflected in socioeconomics. Poor communities, rural communities have more difficulties than wealthier, mostly white communities have. And so the structure is built to provide inequities. I mean, it's done purposely like that. This didn't just happen. And so one of the things that Physicians for National Health Program advocates is for equal access, and that we have a single payer system, which means there isn't a financial barrier. Everybody has the same access to care. You get the same benefits. It would include drugs. And one of the things this would also do is promote resources to be located in areas of need versus areas where they can be made, where they can make money. Right now, the driving force for providing resources is a financial benefit. I mean, why would you have, where I work at Cook County Hospital, it's in an area they call the Illinois Medical District. And there, along with Cook County Hospital, there's a large VA hospital, there's a University of Illinois hospital, there's Rush University Hospital. So you've got these large academic centers within a mile. And then 5 miles west of that, there's nothing. And it's like, when you go to an intersection and stop at the light, you would never see 4 fire stations at each corner, because they can't provide care they can't put out fires everywhere if they're all in the same place. And so we have to have that same outlook, looking at where resources are, and they can't just be placed in an area where it's financially advantageous. It has to be where people need them. And that's the biggest thing that we have to do to provide access, is remove the financial barrier and put resources where people can reach them.
Thank you. Yeah. Of course, Jesus, if you want to respond or not, it's totally fine.
Yeah, I think that was beautifully stated by Dr. Rogers, in that some of the challenges we face in the current for-profit system is that, well, how do you make more profit? You need more customers. You need more sick patients who are able to pay. So, I'm pretty sure we're aware of some of the tactics that are used, such as not insuring high-risk patients or limiting the scope of coverage to those high-risk procedures, like bone marrow transplants are rarely done, even if they're life-saving. And then if anyone has dealt with insurance personally, we have deductibles and co-pays, and a lot of business models practice on claim denials, where they'll deny your claims, assuming that you're gonna accept and not challenge the outcomes. Then to further add, or at least speak on my perspective, so I'm representing the Do No Harm Coalition. It was a chapter originally started out of the UCSF Bay Area. So our main goal is to accompany communities in their struggles, both against state-sponsored violence, such as police brutality, and also to advocate for them on their behalf. And one of the things that I like telling I founded the Las Cruces chapter here in New Mexico. One of the things I told the other students was to be aware that it's not necessarily about our personal struggles, but rather the needs of the community and their struggles. Because most of us in medical school are from bigger cities. Most of my classmates are from SoCal, New York, Florida, from major metropolitan areas. So we tend to forget that there are a lot of rural communities who go without those resources, or who don't have a voice. And that's one of the reasons why I wanted to speak today. It's because oftentimes those rural communities get overlooked. And just to further add in terms of what we're trying to do, I'm often challenged by either my peers, family members, or society as a whole. And I'm told, as a medical student, why are you advocating? Why are you politically involved? And my rebuttal has always been, we can learn the pathophysiological, but we're not going to really be able to treat patients unless we understand not just state-sponsored violence and how that affects them, but also those racial institutions that have been preserved and that create many of those health problems. So this was never, as I tell people, and this has been quoted often, it's not so much that I'm advocating or being politically active, but rather I see this as a form of preventative medicine. This is healthcare at its very core. So thank you again for allowing me to be here and speak. Thank you.
Thank you. I think that's a really nice way to summarize it all, is just that, we can't really practice the extent of what we trained for all these years to do, whatever profession we're talking about, without addressing these concerns that come out, in the world outside of the hospitals. So I think that's a really important point, and something we all experience as healthcare or budding health professionals every day. So thank you for mentioning that. So kind of related, and maybe, kind of a follow-up to that. So what is your vision of how healthcare can be equitably and justly practiced for the communities we serve? So what are some ideas, or what do we see in the future for how we can help this problem?
Well, one of the things that I see and that, PNHP supports is there needs to be, as Jesus mentioned, is that we need to focus more on preventive care because what we have now is sick care. Once you get sick, I mean, you can go to any emergency room and they are obligated to see you by law. But if you need a flu shot, where can you go? And so there's not a lot that this country does not focus on primary care. It does not focus on preventive care. If you look at the numbers, less than 10% of this country, even those with insurance, have their preventive care needs met. There's a lack of, cancer screening. Even with children, there's not adequate immunizations. I mean, fortunately, a lot of schools mandate that, but we don't focus on preventive care. But one of the things that, to be equitable about this is to make it so that everybody pays the same. Because right now, patients have different values. And the value is not related to their life. I mean, it's not a value based on because they're another human being. Their value is placed on how much they get paid, how much the provider can get paid for providing care to that patient. And because you have different values for patients, you have different sources of care for these patients, which in itself is unequitable. Medicaid, which actually covers, it's the one big provider that covers most of this country, has the lowest reimbursement rate. And you can't even function if that's your total reimbursement. It does not reimburse enough to cover your care. The same thing with Medicare. It does not reimburse enough to cover your care. And that's why with private insurance, the prices are so skewed because the places have to make up the difference in what their costs are for providing this care versus what their reimbursement is. And that's part of the reason why market forces don't work. It's not a regular market. It doesn't function the way markets do when you talk about buying groceries or cars. So the fact that we've already devalued groups of patients by the way that they are insured, you can't have an equitable system based on what we have. By definition, you can't do that. And so one of the things by having all payers, by having a single payer system that pays the same for every patient, it doesn't matter if you are very, very poor versus very, very wealthy. A physical exam costs this much, period. And that's what that provider gets paid. So we have to acknowledge that right now it's a system that's based on finances and wealth cannot be equitable. And there's no way it can be.
Thank you. Yeah. Jesus.
One of the things too, I just add is that we have to understand that healthcare in itself doesn't provide health if we don't also address the social determinants of health. And I know as, a teacher in an academic institution, I would fuss all the time about how, just increasing insulin doesn't control a diabetic if you don't know how they're eating or what their resources are for food. And you can't order a multitude of tests for someone who has issues with transportation or is homeless. And so if you want to provide good care and make good decisions in deciding what a patient needs or what kind of testing they have to go through, you have to have an understanding of where they live and what their challenges are. And unless we ask questions, and I always preface it by saying, I'm not being nosy, but I just need to know. And I can tell you that there are a lot of times when delving into that aspect of how patients are actually living day to day, really, it allows you to give better care because then you can adjust what you want to do. You can make changes in what you decide is needed by accommodating and trying to also get social services involved in helping addressing the obstacles and the struggles that patients have receiving that care.
Right. Thank you. I think that's very enlightening as far as, of course, yeah, how can a system be equitable just by definition the way it is right now? So thank you. And then Jesus, do you want to address anything else from that question?
Briefly add to that. I think we have to accept that, capitalism works great for certain system models, But if we apply it to healthcare, by definition, there's going to be unequal resources and unequal care. So that's going to violate what we're being trained for as professionals and the services we can provide. And as Dr. Rogers mentions in regards to a single health payer system, you know, everyone needs to pay their fair share. You know, it's understandable that there's people in the lower socioeconomic status, but we have a lot of very, very wealthy individuals who are not paying their fair share, or actually not paying anything at all. So if we had a system where a certain percentage of your payroll taxes or your income was deducted into a more universal, broad scope of coverage, you know, that would benefit a lot of people. That would benefit a lot of the marginalized communities. You know, along with that, we need to, you know, decrease the out-of-pocket costs. And part of that is due to the really high administrative costs. So if we look at, you know, if we look at a hospital system and the way it's run, I believe, I'm probably gonna get this number wrong, it's somewhere between 16 and 30% of their budget goes towards overhead costs, such as advertisements, and they have legal teams and research teams, and it's not always research teams in terms of how can we provide the best affordable coverage, but it's more of in the sense of how can we charge more, how can we save more money, what drugs can we cover that would be more beneficial to, you know, to the company's bottom line. And then finally, public subsidies. So there should be some form of government involvement, and also to just limit copays. You know, I think that's one of the tactics with copays and deductibles that insurance companies, you know, that's what they use to pass on the cost to the patients. And that, to me, seems unfair and inequitable.
Absolutely, thank you. Yeah, definitely, you know, copays, and then also just like price transparency, which we have basically none of in this current system, also falls into that as well. So I'm glad that was brought up as well. Kind of related to that, so we kind of talked about what could be made for the future, what could help the system become more just. So another look, you know, how does privatized insurance and the corporatized nature of healthcare that we have right now affect what we can achieve as healthcare providers?
Well, private insurance is nothing but a middleman. And we should be clear, Blue Cross does not provide me any health care. They just provide money to the person who does provide me health care. So when people keep talking about, I like Blue Cross or I like Aetna, no, you like your provider, because that's who you had the decisions and that's who gave you your care. And so we have to be clear that, why are we giving all this money to this middleman? Why can't I just go straight to this doctor that I like seeing? And then the government will just pay him for the care that I need. And that's what single payer is. You get rid of this middleman, and they make phenomenal amounts of money. And Jesus, you're right. There's about 25% of hospital income that goes to administrative costs. If you look at large hospitals, they have more billing agents than they have nurses. And those who have worked in the clinics, you know, sometimes you can't find a nurse, but you know exactly where the billing agents are in that hospital. You can find them very quickly. So it's not geared towards providing care at all. And these middlemen, they're doing nothing but denying care. And that's what people have to understand, and that it's impossible to know what your coverage is. Like if any of you broke your leg tomorrow, how many visits to rehab will you have after you've been in a cast for 6 weeks? You don't know. And you can't even find out. If you read through this 25-page with a font of 4 booklet that your insurance company gave you, it's impossible to tell really what your coverage is. Whereas if everybody has the same coverage, and believe me, it'll have to cover everything. Otherwise, wealthier people will not tolerate it. So as long as they're making the demands for care, everyone will be covered for everything that's necessary. And it's very easy to figure out what you need, and you won't have narrow networks. You can go wherever you want to get what it is that you need. I don't know if I answered your question. I got to talking and I forgot what you.
Oh, that was perfect. Thank you. Thank you.
You know, I'll quickly chime in terms of some of the challenges with the corporatization and privatization of health insurance, as many of you might have already encountered in your training or my preclinical training, is we'll go through organ systems and we'll have our professors and our clinicians and physicians discuss these marvelous drugs, but they always come with a disclaimer. They're like, oh, but that's too expensive. You know, most health insurance won't cover that, or procedures or imaging or labs. And it just seems kind of frustrating where, as a future healthcare provider, I'm going to be limited in terms of what I can do. And it really seems unfair to the patient because by definition, they're not going to be receiving the best treatment possible. They're going to be receiving the best treatment possible that their insurance covers.
Yeah, one of the things that, you know, having trained and spent most of my career at Cook County Hospital, now called Stroger Hospital of Cook County, when I went there as an intern, it was almost like a single payer system. Not once did I ever ask a patient what their insurance was. Not once did they ever ask me, how much is this medicine going to cost? Because within our system, all the coverage was free. The decisions about what needed to be done, what you wanted to be done, was made between me and the patient. The cost never came into it. Now, over the years, it has changed, like healthcare everywhere. The delivery of care has changed. Whereas now with the privatization of Medicaid and Medicare, it becomes more difficult because I don't know what medicines will be covered. What can I write for this patient without having to check? And so that it's become very different. And one of the things that I like to say to students who are working for single payer is that one of the reasons that I really enjoyed clinical medicine was because of my experience at County, where it was like a single payer system. And what it was, that made me really like, I got to learn my patients. We made decisions together, whereas now it's not like that. And now physicians are overburdened by administrative mandates, and you can't do this, and you have to talk to this first person first. And meanwhile, your patient is suffering because you can't figure out what can be done, let alone what needs to be done or what you want to be done. And I really want you to enjoy being a clinician the way I did, because I just so much enjoy it. Now, I'm not a researcher. I mean, if that's what you like, that's fine. We need everybody. We all have to find what we like doing and what we do well. And I think that it's going to be more difficult being a happy clinician under the system that we have, because you're not making decisions. You go through all this trying to figure out what is wrong and what you want to do, but it's not up to you anymore. It's not a decision between you and your patient. It's somebody else who's sitting in on Zoom, I guess now. They used to be in an office room, but it's somebody who's totally distant. And therefore, there's no personal interaction. There's no personal cost to them when they make decisions to deny care. And I can tell you that the burden on a clinician, knowing that you can't do what you know needs to be done, can be extreme after a while. And I think that's leading to more burnout and dissatisfaction with being a clinician. So you all really need to work hard to get single payer approved so that you will be happy clinicians as you do, because it becomes very frustrating, but we really do need this just for the sake of clinicians and for patients. We both should be happy.
Absolutely. Yeah, I think I definitely agree with, especially with everything you both have said, and Jesus, coming from a medical student perspective as well. I can't think of a day in my last 2 years of clinicals where insurance wasn't a burden or part of the conversation in our patient care, when we should be discussing, why we're prescribing certain antibiotics, and instead of time spent learning as a student or better performing care for a patient, we spend time arguing for, oncology meds that are, hundreds of thousands of dollars. And it really is disheartening, and there's quite an emotional burden. So I am happy that we can bring that up as future professionals and discuss that. So the next question kind of changes gears a little bit, but it's something to also think about. So what do you guys feel might be lost by community healthcare efforts getting absorbed by like the state? So one example that we included from the past was the Black Panther Party's People's Free Medical Clinics. They got folded into FQHCs. And that's just one example, but can we just thought if you guys had any thoughts on what could be lost if we went towards a state system?
Well, I'll go first again, Jesus, unless you want to answer that. One of the things, if we look back at the Black Panther Party, because when I'm dating myself and showing my age, but when I was in high school in Chicago, where the Black Panthers were very active, I was very much aware of what they were doing. And Quentin Young, who was one of the founders of PNHP, was one of the physicians who volunteered at one of their clinics here in Chicago. And if you look at what part of the problem why their clinics could not endure is because the Black Panther Party was framed as a group of angry and armed Black men. And no matter what else they do, this cannot exist. This is not sustainable in this country. And that persists now. Every Black man that gets stopped is considered armed and dangerous until proven otherwise. And it never gets proven until they're shot. And so this whole vision, this whole underlying concept has not changed. And we should be aware of that. And so what happened with the Black Panther clinics, and they were, staffed by all volunteers. Doctors came in, and people involved with the Medical Committee on Human Rights that got Johnson to sign the Medicaid and Medicare bill. And Dr. King was actually the only Black person, and Dr. Cobb, who was from the NMA, he was the only doctor at that signature when Johnson signed that bill. That in order to keep providing care in those clinics, you needed a staff of volunteers, which is sometimes sketchy, and things just fall through the cracks. Your funding is not always consistent. And so when FQHCs came about a few years after the People's Clinic started, these were all government funded, but they had a mandate in that they were to provide care in those communities. So the destruction of the Panther Party was not just about destroying their healthcare, it was destroying that party because of the vision and the way they were framed. It wasn't that the clinics did not function. They weren't really sustainable because the funding, like I said, and the staffing was not necessarily consistent. And then when FQHCs came about, which was, based on the framework of the Panther clinics. And one of the things it did was it involved the community. So it's not like the state is saying to this neighborhood, this is what you need to do. The community board, which had to be at least half community members, said, this is what we need here and this is what we want. So having been a medical director at such a clinic, it was a whole community effort. I didn't dictate anything. I didn't say, well, we're going to provide this and not provide that. It wasn't like that at all. It was a community effort. And one of the things that FQHCs have too is a lot of social services involved, a lot of other resources, because as we know, the social determinants of health are just as important in the health of that community as what I decided, what medicine as I chose for their blood pressure or the prenatal visits. One of the problems with FQHCs, though, is that they tend to be, it takes a lot of work to establish networks for tertiary and hospital care for those patients. The 330 funding that funds FQHCs doesn't provide for the healthcare when this pregnant person goes to deliver. And so you have to have arrangements with hospitals to provide that care. Where I was, we had an arrangement with Northwestern, but it dependent more on individuals saying, okay, I will do this, versus the Department of OB-GYN saying, yes, we will do this. And so it's a difficult arrangement. And so sometimes care does fall through the cracks. but it clearly has made a difference. And I think now there's, how many thousands of, there's not how many hundreds, there's not multiple thousands, but there's hundreds of clinics throughout the country that provide this care, and many are associated with medical schools. You all volunteer at those places. Some of the faculty goes and volunteers at those places, so that they're an integral part of the healthcare here. But again, it increases the fragmentation that we have in our system because their funding is still separate. And so it's not, we don't have a unified way to address healthcare. Now, FQHCs have made tremendous difference in the healthcare in poor communities. I will say that. And they should still remain in a single payer system. They would just be funded by this system.
Right.
And the community involvement would be the same. So I don't think that, it's not that we would have outsiders necessarily dictating what these FQHCs will do. I think that they should be able to maintain their governance the way they are, where they still have boards. They're non-for-profit organizations, so that, which is consistent with what we want. So I think that they would be an important part of the system. And since they're not funded by private health insurance, this is what they do. So they'll be fine. Yeah. And their funding could possibly be increased under single payer, since things would be globally budgeted. They wouldn't have to depend as much on private donors to function.
Right. I think that's an important part to say, does not, we can have these remain in a single payer Medicare type system without really changing what they do, but just where the funding comes from and making sure the funding is more equitable to what their needs are. So like needs-based funding. That's a really important point. So thank you. And Jesus, was there anything you wanted to add, of course?
My scope of knowledge on this topic is very limited, but based on my experiences here in the Southwest, we do have FQHCs with in El Paso, which is our neighboring city. And one of the things I observed between the FQHCs is that there's more regulations, which can be good or bad. I can't really weigh in on that because it is geared towards helping that specific community, and that's one of the benefits. The majority of the employees are from that community, so we're particularly dealing with an immigrant borderland population. But there are certain restrictions and limitations compared to other health advocacy groups, free clinics, where there's sort of more freedoms, and that could be good or bad. As a medical student, you get more hands-on experience in those free clinics, but then there aren't as many regulatory agencies, and the funding, some of our HQCs are poorly funded to begin with, but funding seems to be more consistent if it's federally funded than if we wait on outside agencies or charitable donations.
Thank you. Also very enlightening on that topic. It's something I need to learn more about continuously. I'm going to kind of switch gears a little bit towards audience questions, just because Adriana's been compiling some really good ones, and I kind of want to hit some of those before we run out of time. So I'll just kind of start maybe from, or what do you think, Adriana, from the top, or any?
Yeah, you can start from the top, or pick like questions that you think would be most salient. I also just wanted to say, if you would prefer to unmute and ask your question, you can put stack in the chat, and we can unmute you. You can also just type your question in the chat to everyone, and Stephanie will ask your question. If you don't want to be associated with your question, you can directly message me, and I'll add it to the audience questions for Stephanie to ask. So lots of options for you to ask your questions.
Awesome, thank you. For now, I'll just start with the first one here that I have. So this was written as, many clinicians think it is not their place to call for racial justice. What do you think is the role of physicians or healthcare workers in calling for racial justice, as well as other social change?
I think that's an interesting perspective, because I think it's every person who lives here, it's their role to call out for racial justice. I don't know why a physician would think that that's not their responsibility as someone living in this country. And it's not that, I mean, I don't know what that means. I don't know why physicians would say that, other than they're removing themselves and isolating themselves into this scientific box where supposedly things are objective. You know, you follow your guidelines, you look for your evidence, and then you base your decision based on that. But we all know from working with patients that guidelines are just guidelines. They're not, there's reasons why you don't follow guidelines. You have to justify that. But I don't know why, you know, as a physician, just because you work in science, that you cannot become active, or just working in an occupation that involves treating people. I think it's your responsibility to call out for social justice. I mean, it's to ignore that and not think that that's a problem is a problem in itself.
Thank you.
Yeah. As I stated earlier, you know, I don't, you know, I never wanted to be involved in politics, but it's undoubtedly our role. And I don't see this as politics, but rather as preventative medicine. You know, I'm not going to necessarily endorse one candidate over another based on a political party. I'm going to endorse them. I'm going to endorse their views and how they're going to affect our patient population, our community, the future patients that I'm going to be providing care for. So I don't like thinking of this as being politically involved. It's preventative medicine at its core.
Thank you. That's a really,
I'm going to use that. No, go on.
oh, sorry. No, I didn't mean to interrupt you. Anything else either of you would like to add on that question? No? Okay. So let's see. So this one's kind of interesting, relating to practicing in rural areas. So what do you think would be the best way to encourage physicians or other healthcare professionals to move and practice to rural areas? As we kind of know, that's a need right now, and something that Medicare for All might hopefully help us with. But what are your thoughts on that?
That's an excellent question, and that is apparently that is a problem a lot of medical schools are being challenged with, fitting those roles. One thing Burrell College does is they have tuition assistance. So if you commit to doing your clinical rotations and your residency in Eastern New Mexico, which is, we're talking towards Roswell, you know, where the aliens landed supposedly, but you know, it's desert land, it's empty. So if you commit to that, you know, you don't have to worry about those student loans. So it's a sort of a trade-off. Now, in terms of keeping those doctors long-term, I think that's a great question, and there should be incentives. And I know there are programs that offer, you know, loan repayment programs. So I think that's one way to start, because it has encouraged many of my classmates to say, hey, you know, I'm from a big city, but I'm okay working in a rural community. I'm okay training in a rural community. I'm okay serving a rural community.
Okay. Thank you. Yeah. And Dr. Rogers, yeah.
Well, yeah, the issues of rural healthcare are directly related to funding, and also just the geography of rural communities. You have little pockets where people live. It's not like, you know, it's congested, or everything can be nearby because of just the way it is. If you look at hospital closures, there's been, I think, 1,200 rural hospitals, or 120 hospitals that have closed in the last 10 years in rural communities. People have about 30 miles to go from home. That's the average distance to a healthcare resource. And people go bankrupt when they go to provide healthcare, because they're often airlifted to another place that has tertiary care. If you present with an ACS, for example, and this small community clinic or whatever can't take care of you, you get airlifted out. And so the expenses of that are just phenomenal. So that one of the things that a single payer wants to do under Medicare for All is one, to increase the reimbursement of primary care providers so that they are willing to go to areas like this, along with just changing the way that hospitals are paid so that they can be healthy and financially solvent no matter who their payer source, because it's all the same payer, and that they can take care of that. One of the things that when I was in school, there was the National Health Service Corps. I don't know if that's still active. It was very large when I was in school. And what it did is it paid for tuition. And then you were obligated to the certain amount of time, depending upon how much money you took from the service corps. And you were allocated to an underserved area, whether it was in a rural community, whether it was a poor urban community, whether it was the Indian Health Service. That was what you did to pay off your loan. And I know some people ended up staying in those communities because that's what they liked. That's what they wanted to do. So it's not like you're sending people, like prison, do your time and then you can come out. People liked what they were doing. They were doing the healthcare that they wanted to do when they went to medical school. So bringing that back would help address some of the inadequacies, especially in rural care. One of the things too is to add transportation as one of the parts of medical care that we provide. That, if people don't have a car, how do you get somewhere that's 30 miles away? I don't know. If you don't have someone to, and it also makes it impossible for people to visit you if you were in a hospital that far, so it isolates you. So there's a lot. It's like addressing the social determinants of health. You have to acknowledge what the issues are and then have processes that address those. And that's why when you have a structure that is built on people who have access to whatever they need, you're going to have issues like this. And that's why if we look at communities, see what they need, and then you provide those resources that provide the healthcare that they need and the other services so that they can access that healthcare, it would help address that problem. And it's the same thing in urban areas. If you look at poor communities, there's often inadequate transportation. I know the patients that sometimes I would see at county took 2 buses. And I can tell you, I gave away a lot of money for cab fare to especially older patients who would see me in the clinic. In Chicago, it's dark at 5 o'clock, and they don't need to be standing on a bus stop. Fortunately, I was able to do that and willing to do that, but there should be a system that does that. It shouldn't be, just like everything, it shouldn't be based on or function because of individual actions. There should be a system that supports individuals and helps, provide the solution. And that's what we don't have now, because it's like we've said multiple times, it's a profit-driven system that is not based on helping the patient get what they need or providing the care that's needed. It's whatever will make money.
And to add that, I'm going to plug for New Mexico and at least Doña Ana County, which is on the border of actually Texas. And one of the things in terms of community programs with the vaccine effort is they're relying a lot on volunteers. So we have basically 4 entities, and Dr. Rogers brought this up in terms of transportation. So I'm not involved with this program, but I know my partner is, so she always tells me about it. So basically they're using the volunteer fire department to go to people's homes to vaccinate them. It's a more elaborate effort. They're using, retired nurses, medical students to schedule those appointments and help with the vaccination, but they're sending volunteer firefighters to those rural communities because some of those communities are literally not accessible. The mail delivery service doesn't go there. So I think that's one of the beauties of at least this county, where we have a lot of different groups coming together. As I mentioned, the fire department, we have our medical students, we have Medical Reserve Corps, which is composed of medical students and retired physicians, retired healthcare providers, and the fire department and the Department of Health of New Mexico. So all 5 entities coming together. And, I think we're doing pretty well when it comes to vaccinating our community, because just to put it in perspective, we have 100,000 residents in our county who live in Las Cruces, which is the major city. but we have 100,000 more that are spread out. You know, we're talking about an hour to 2 hour drive away from the major city.
Wow. Yeah, no, thank you for sharing all that. And it just, I mean, it's like a positive thing that it's like, you know, to have all these groups come together. But as Dr. Rogers and you, Jesus, said as well, it's like, why don't we have something that's supporting these efforts from a more centralized location so we can better do this work for our patients? But that's amazing that that's what's
And
going on.
most of us are, just to add to that, most of us are volunteers. The National Guard gets paid, but all the Medical Reserve Corps, the medical students, the fire department, we're all volunteering our time.
Wow. Okay.
Yeah, transportation is an issue that we often don't think about. And I know if you look at just COVID testing, you know, there was a lot of drive-through testing, but not everyone has a car. And so when you make a policy that, you know, disenfranchises a majority of the people, I mean, that's the structural racism that this country is built on, that you just, well, I've had a car all my life. Doesn't everybody have, you know, that whole attitude, and that there's not an acknowledgement that you have to do more in some places and less in other places, but you still have to do in both places.
Absolutely. Very related to that, so kind of we'll just continue the subject here, and this will probably be our last question. If you guys have any thoughts on kind of the already existing Indian health services and how Medicare for All might, even just your thoughts on that in general, or how that may change how they deliver care, or any further thoughts on those two systems kind of.
Well, one of the issues about the Indian Health Service is the way that tribes are defined. You know, there's some legal tribes and acknowledged tribes. So not all Indigenous Native Americans are included in the Indian Health Service. So and the whole idea that you have a separate service is ridiculous. Mm-hmm. I mean, it just builds on the inequities and plus their funding is abysmal. It's abysmal. So that whole concept, I mean, it just continues the devaluation of those lives by having an Indian health service. Even called Indian is derogatory. So, you know, just to have this service is just ridiculous, and that they would be included no matter if their tribe is acknowledged or not. They're living here. They are covered by single payer.
Right. Absolutely. Yeah, it's yet another example, it seems, of, again, all these kind of pop-up ways that we've tried to cover, piecemeal cover populations, and it just won't really need to be there if we have a system that covers us all.
Exactly.
Jesus, is there anything else you'd like to add in that, or any other thoughts?
Yeah, that there's a lot of times the myth is that these Indigenous reservations are these small cities or small towns. They're geographical areas. The people are spread out. You know, just as a little trivia. So we have Apache from the Trail of Tears who were, you know, forced to relocate here, and they're not in, you know, we can't give you specific coordinates. And again, being in a rural area, they're going to still face those same challenges of, you know, the system being underfunded and lack of transportation.
Absolutely. Okay. Well, we're kind of getting near the end. I guess we just wanted to kind of give you each a chance to kind of plug any organizations or anything you'd like us all to reach out to. I know we've kind of dropped a couple links in the chat. There might be a few other ones of maybe like Do No Harm or other coalitions that we would love you guys to reach out to, but I'd like to open the floor for you guys to kind of give some plugs if there's anything.
I mean, I think, you know, as Dr. King said, of all the social injustices, healthcare, the denial of healthcare is the worst. And there's so many other things in social justice, social injustices that, you know, we have to look at them all, and especially with what's happening in this country. I'm hoping that this country will see how violent and how people are treated so inequitably on so many different levels. We used to think that, sliced bread was the best thing that ever happened. I think the video iPhone is the best thing that ever happened, because who knows what has been, we all know what's been going on, but now that it's videoed, you can't say it doesn't exist. And so I think that these all have to be addressed in common, because you can't stop the police from being violent if you don't address all these other issues. And it makes no sense to make sure that everybody is so healthy if you still are risking your life driving a car.
Right.
So that we can't look at these things as isolated social justice issues. They are all in the same bowl, and they are all important. And fixing one without addressing the others, all that happens is you come up with a new way to create the initial inadequacy. It's like structural racism. The only thing that changes is the mechanisms. As long as the structure is there, there will still be racism. There will still be the injustices. There will still be the inadequacies. So even if, we have a single payer, we have to be diligent stewards of a single payer system so that it does give equitable health care. The desegregation of schools did not desegregate the schools. They are just as desegregated. The voting rights law acted okay for a while, but now it's being dismembered under the guise of voter protection and election protection. So the mechanisms change, but the whole goal of disenfranchising Black voters is still there. And so we have to be careful and really diligent that just passing a Medicare for All bill is just the beginning. It is not the goal. It is just the beginning.
Thank you. Absolutely. And Jesus, any final remarks or organizations you'd like people to get involved in?
Of course, Do No Harm Coalition does an excellent job in, they train street medics. And if you're not familiar with the concept, is we accompany communities when they're protesting and during their activism. And we have different training models. And that's currently something I'm working with at Burrell, is to establish a street medic sort of maybe like certificate course that involves de-escalation training, which we know would be useful for law enforcement, but I feel that would also be beneficial for healthcare providers. But just as a final thought, I think we shouldn't limit our scope of practice to the clinics or hospitals where we work at. I think we need to expand our horizon into the communities that we serve.
Absolutely. Absolutely, guys. Thank you so much for sharing all of that. And I hope this was, helpful for everyone to just get some thoughts out. I wish we had more time to continue to discuss. I'm going to throw it over to Krita. She's going to make a quick announcement and we'll talk about the next steps for the day. But I want to thank you guys again for coming, and thank you so much, panelists, as well.
You're welcome. My pleasure.
Thank you.
Hey guys, just wanted to plug in a reminder for the call to action. We are targeting Representative Dwight Evans in Pennsylvania 3rd District. He used to be a supporter for Medicare for All and has since fallen off as he started receiving campaign funding from Blue Cross Blue Shield. So we're calling him out on Twitter, and it's already started creating waves as his office has deleted the last his old tweet that said he was a staunch supporter for Medicare for All. So we're pinging his attention, and we're going to follow up locally with the chapters in the area. So please add to that. It takes 2 minutes to do. We have I'll put the link in the chat. We have his phone number to call his office and leave a message, and then tweet at him. And yeah, it should take no time at all. And I'll pass it over to Stephanie again to talk about next steps.
Okay, guys. Yeah, thank you, Krita. That's helpful as well. So next we're going to be doing the Midwest Breakout kind of regions. So you'd want to attend whichever one that you're a part of based on the state or the program that you're with. So I think, are we, Adriana, I'm not sure, are we putting links in here for that? Or you guys should have them already from the previous announcements as well?
I just put them in the chat as well, the links
you
for
did.
each of the regions. Yep, and they'll be starting at 3:30, 3:45.
Okay, yep, so 3:45 or whatever it is on all our different time zones, please. But thanks again, you guys, for coming. I appreciate it. Obviously, this is an ongoing fight, but we're all about building this fight together with other organizations and keeping the conversation moving throughout all of our years of training. So I'm happy to be here and happy to continue this work as a resident next year and hopefully with all of you guys. So thanks for coming, and we'll see you at the next session.
Thank you. Bye.
Bye, guys.